All right, thanks for introducing yourselves in the chat. Looks like we have some wisdom participants, which is great. I'd love to hear your questions. And we'll get started. So just to start off, I hope everyone can see my screen. But I am Allison Fiscalini. I'm the director of the Athena Breast Health Network and the Wisdom Study, and I help to moderate these forums each month. And so I'm really happy to see so many people here today, and we'd love to make this an engaging session. So please do ask questions. Please do, interrupt, ask those questions. And this is really meant to be a time for everyone to participate. So with that, I will get started. So I'm going to leave it in this presentation mode, if that's okay. It will allow me to see the chat. But again, if you've just joined, please do introduce yourself in the chat. And if you want to add what brought you here today, that would be great. Let's see. So as I mentioned, the format for today's session, we do want to hear from you. We want to see and hear your questions either via chat, or you can raise your hand or speak up during the question and answer session. If you are not speaking, we do ask that you mute yourself so that we can hear the speaker clearly. And we are recording the meeting. We do share these on our website or on our YouTube channel, really just for people who aren't able to join and want to use this session in the future to learn about the study or some of the information that we are presenting. And then we do have a short post-meeting survey that will pop up at the end, and we'd love to get your feedback. Again, this is something that we have been doing for now, let's see, a year and a half or so, and we'd love to hear feedback so we can continue to improve upon what we're doing and provide you with the most relevant and interesting information possible. All right, and our mission for these community forums are really just to move together in a conversation and think together so that we can move toward equity and better outcomes in breast cancer for everyone. And so a lot of the topics that we will talk about and have talked about have come from you as our audience, of trying to understand what is most important to you, what topics you feel are most important and you want to learn more about. So we have a whole bunch of other forums that we've done in the past. As I mentioned, they can be accessed via our YouTube channel. There's a link on our Wisdom Study website, www.thewisdomstudy.org. And would encourage you, if you'd like to listen to any of these, they're all available to you. If you have any trouble accessing them, please do let us know. We're happy to help. But for this month, we're going to be talking about breast screening and breast screening guidelines. What is breast screening? Why do we do it? And some information about the guidelines that are out there. So with that, we will talk about breast screening guidelines and also what the most recent draft means for you. And I will introduce, I thought I had a slide with Laura Esterman, who is our speaker for today. So I'd like to introduce Laura. She's the overall principal investigator for the Wisdom Study and also the director for the Breast Care Center at University of California, San Francisco. So she will be talking to us today about some background on breast screening and also answer any questions that you may have. So with that, I will let Laura get started.
Okay, so thanks everybody. And I think to really help everybody understand what's going on with these new guidelines, I feel like it's really important to go back to basics and just talk about what are the principles of screening and how we can talk about it. And some of this, may feel a little confusing. If you have questions, please stop me, but I'm going to try and go back to the beginning and go back to the basics that really led to our launching the Wisdom Study in the first place, okay? So, yet again, we have a whole set of new guidelines, new recommendations from American College of Radiology, a bunch of other guidelines that haven't changed. And, quite frankly, again, women are caught in the middle of this controversy. You have primary care physicians ordering one set of tests and, recommendations from the radiologists that are different. And, how is it that we've come to this? And so I want to go back a little bit to talking about some of this. And again, this is meant to be a conversation. I'm going to go through this. When you have questions, you can either raise your hands or put something in the chat and Allison can call on you, okay? So let's keep going. So it turns out that there are 7 different clinical guidelines in the United States, and there have been disagreements over how best to screen for over 15 years. And a lot of the guidelines actually turn out to be political. In Europe, we'll get to this later, there are actually 3 guidelines, but no one is screening women in their 40s. The data we're all looking at is the same. It's data generated from the 80s and early 90s, and very little new data has been generated. The 2 personalized screening trials are Wisdom and MyPubs in Europe, and they haven't read out yet, but that's actually part of the problem. So how can it be that everybody's looking at the same data, and yet we have things that are so different? And, we've got the annual screening from the American College of Radiology, and they actually put out some new guidance about what to do with breast density, and which is, which is adding an MRI for a huge number of people, which, we can get to what some of that would mean. And I think we have to be really thoughtful about what some of the problems are with screening before we go lunging into, screening that would have a huge burden, especially if we don't understand really what it will reveal. The US Preventive Task Force guidelines before were every other year starting at 50 to 74, unless you were identified as having a particular high risk factor. Then it would be a shared decision-making discussion with your primary care physicians, and now they've extended that to 40 years. And we'll talk later about why I don't think that's really so sensible, but nonetheless, that's where it is. Then we've got the hybrid of the American Cancer Society, which is 40, starting at age, 45 to 54 of annual mammograms, and every other year starting at 55. And then there's several other guidances that are somewhere in between. Let's go to the next slide. So, next slide. Yeah, so the newly updated US preventive guidelines were drafted in 2023. There's been a lot of comments put in, and as we said, it just moved the every other year starting at 40. The intention is to catch cancers earlier, but again, I think the issue is that all cancers are not the same. And if you've got a risk for fast-growing cancer, screening every other year doesn't make sense. So the good thing about the draft recommendation is that it calls for research in key areas. So that is certainly what we are doing, and we're trying to come up with things that are better and more personalized, and we'll try and go through some of that for you. Next slide. So the rationale for lowering the age was really not confirmed. I think there's anxiety generally about, and a lot of pressure about, whether we should start in the 40s. But, there is evidence that screening based on an individual's risk at a given age is, more, it increases, if we can do their risk instead of a specific age, we could increase the efficacy and reduce the harms rather than just doing something based on age alone. It doesn't make sense just to do age alone because, most women are not at risk in their 30s. Most women are not at risk in their 40s. By and large, most cancers show up much later in life, but there are some specific people who are at increased risk. And it makes more sense to try and figure out who those people are and try and focus our tools on that, but not just screening. Really, the intention of understanding risk is also to see if there's something we can do about it. And we'll go into more data. And okay, next slide. So again, just as a point of reference, Whatever you think of the rest of the world is still looking at the same data. So if you're in the US, right, so it used to be that you would get a mammogram once a year. Now it's every 2 years. It used to be every 2 years starting at 50. If you're in France, you don't start your mammograms until you're 50, and you'd screen every other year. In the UK, you wait until 50. You only screen till 65, and it's once every 3 years. They do not have a higher mortality rate for breast cancer than we do. And in fact, in Switzerland, they felt like the data was so lacking that they've stopped their national screening program altogether. So yes, it's very controversial. And so again, why is that? It seems so sensible. Why not just, we've heard for decades that early detection saves lives. Why not just screen everybody and let's not worry about it? So let's go to the principles of screening. Keep going. So I think the biggest problem with all the guidelines is that they are not looking at the variety, at each individual's risk, nor are they understanding that all cancers are different, right? We've talked about this over and over again. Breast cancer is not one disease. There are some that are very slow growing, and there are some that are very fast growing. These are very different cancers. Today, we would never treat those the same. And we also know that people have very different risk. Some people could have extremely high risk because they've inherited an error in a gene that puts them at risk for an 85% lifetime risk of getting a cancer. Surely those people should be treated extremely differently than the person who, might have like absolutely no risk factors and not have any genetic predisposition whatsoever. And, again, some of these bad cancers, it's not just that the risk is higher, it's that the risk is shifted to a lower age. Now, the vast majority of people don't have that, but these are things we can actually find out. These are things that we can tell with a pretty simple test, the simple test that we're using in Wisdom that comes to your door, you spit in a tube, you go back, and you can get not only look at these 9 genes that make you at higher risk for breast cancer, but all of the other genes that are inherited along with that together, many genic genes, risk put together can give us a much better understanding on top of some of the other risk models of what your risk might be. So next slide. And again, just, there are, if you think about it, there are some cancers, the perfect example of these may be, everyone's, I think, more familiar, in fact, with the prostate cancer story, the so-called Gleason 3+3 cancers, that are very slow growing or pretty stable and not really at risk. And in fact, 10-year studies of active surveillance for those types of tumors and prostate cancer, these grade of 3+3, the 10-year survival is 97%. So again, what we see is in the United States, about 60% of people now do active surveillance of prostate cancer, and about 90 to 95% in Europe do so. So again, a lot of variation internationally. And part of that, the reason I bring that up is when you screen and when you stick a needle in things, you find stuff. And everything you find is not necessarily something that's going to kill you. And it can lead to overtreatment. That's just true. The more you screen, the more you're going to find things. So we want to be smart about what we find, what we do about them, and how we treat them. And you can imagine a very fast-growing cancer, screening every 2 years probably doesn't make very much sense because you'll miss the fast-growing cancers with screening. So that's why we need to have a smarter strategy. And really, if you're at very high risk for even a very slow-growing cancer or a slow-growing cancer, we actually have lots of tools now, and increasingly we'll have more options to try and reduce risk, which is, that's prevention, and prevention beats screening any day if we can figure that out. So next slide. And I'm going to
And
go through, yeah.
I was just going to say, just to define active surveillance for people who maybe haven't heard that term before.
Sure. So if you have this kind of low grade or low risk prostate cancer, you can just watch it and do nothing, and except be followed and get rebiopsied. The option to that is to have the prostate gland removed. But there are a lot of risks associated with that surgery, a lot of side effects that men do not like. It can cause incontinence. It can cause, loss of sexual function. Radiation can cause an increase in bladder cancer. The long-term side effects from surgery and radiation are pretty significant, and probably much more significant than the very, very, very small risk that this would progress. So there are options like active surveillance and watch and waiting, and we'll talk about that a little bit later for some of the stage 0 breast cancer. So it's very important to kind of look and see how screening has worked in other cancers, because it actually is instructive ourselves for thinking about how we should be planning and thinking about it, and why it is we might say that screening less frequently might make sense, again, for these slow growing cancers, but we really have to think very differently. For the fast growing cancers, fortunately, that's not the majority of cancers. It's 20% of them, or 25% of cancers in the breast turn out to be that more aggressive cancer, but it's not the majority by any means. And we also see that there are differences in those fast-growing cancers. For example, African-American women are more at risk for triple-negative breast cancers, which are fast-growing cancers. And again, screening every other year for those kinds of cancers isn't going to do the trick there. So I think that's part of the reason why they wanted to change it, but I don't think it was the right recommendation. That's the opinion of our whole wisdom group, which is a pretty big consortium of like 50 to 100 people. So we've certainly put in our recommendations. So let's take a look at some other cancers and the principles of screening, which I think is the next slide. Yeah. Okay. So why screen? And again, the condition has to be serious. So if breast cancer didn't kill anybody and it wasn't a serious disease, it wouldn't make sense to screen anybody. It has to be that the condition can be found at an earlier stage through screening, and that those treatments would be better or different or less toxic for an earlier stage. If the treatments are the same and the outcomes are the same, then the benefits of screening may go away. Let me give you an example of how I see the field changing for, say, something like a HER2 positive cancer. We've made so many interesting new drugs that target HER2 cancers. I can imagine maybe in 5 or 6 years that our treatments may be so good, and there may be some really amazing untoxic, antibody therapies that are not toxic, that the treatments are so good that we wouldn't necessarily worry so much about finding these at an early stage. So if your treatments are going to be the same, whether it's stage 1, 2, or 3, and they're all equally successful, then it doesn't necessarily make sense to screen. Now, that's a little bit of wishful thinking, but I actually believe, as I look at the field, that might be possible in 5 to 10 years. So that's just an example. Right now, that's not the case, but I'm just giving you an example of, if we can figure out how to cure them and the cure isn't toxic, okay, then it doesn't necessarily make sense to screen. So this is the World Health Organization's principles of screening. The test has to be affordable. It has to be effective at finding the condition earlier. So again, that's one of the issues about dense breast tissue or not. And the test should not cause a lot of false callbacks or interventions. And that actually turns out, that screening does cause, 75% of all biopsies turn out to be benign. Many of the callbacks, 80%, 90% of the callbacks turn out not to be something, but it's very frightening for women. So these are just realities that we have to deal with, and we have to think about the impact on the population at large. A lot of people say, oh, they don't care until they're called back, and then there's a lot of panic. I'm often on the receiving end of panic phone calls, and it's frightening for people. So again, we don't want to inadvertently bump up the burden of screening if we can do a better job. The data are that if you screen every year for 10 years, 50% of women will get called back. So and 50% of women by no means will have a cancer. So there is a burden of screening. So the whole idea of personalizing screening based on risk is to also be thoughtful about trying to reduce that burden and not create a lot of panic. And people who have multiple biopsies sometimes stop screening altogether, or they get so scared that they want to have a bilateral mastectomy. You'd think that wouldn't happen, but I can't tell you how many people have come in telling me that they're like so frightened and they're so sure that like the next biopsy it's going to find cancer that they want to have a bilateral mastectomy. So it's, again, I'm not saying that's a reason to screen or not screen. I'm just saying that there is a burden of screening in breast cancer for sure. So, and then of course, reminding people that screening is not done in people who present with a symptom, someone who has a lump or a pain or discharge. And so it is also important for people to understand that screening isn't perfect. And in COVID, the people who got into the most trouble were not the people who missed their annual screening exam. It was the people who had a mass and didn't come in, because it turns out that the people who show up with a mass often have the fast growing cancers. Most patients with these aggressive cancers show up between screens. So that's actually one of the places where our current screening falls short. So it's important, if you find something that's different, doesn't matter if you had a normal mammogram 6 months ago, you got to go in and get it checked out. So that's just an important message.
Dr. Esserman, can you just explain a little bit more about what you just said? You said screening is not done in people who present with symptoms. Are you meaning to say that
that's not a screening test? That is a diagnostic test. That's someone who's got a mass. You're really going to go look at the mass. You'll still do a mammogram, but you'll probably do an ultrasound, and you'll look to see what that lump is and do special tests because of it.
So that's considered a diagnostic.
That's a diagnostic test, not a screening test.
Okay, thank you.
Does that make sense to people? Yeah, again, please stop me, and Allison will be monitoring the chat and raised hands. Stop me if what I'm saying doesn't make sense. Okay, so again, screening is not prevention. We're not reducing your risk by screening. And by understanding people's risk, we actually do have the opportunity to think about that. So next here, I'm going to show you some data on colon cancer. So, if you think about it, colonoscopy is now recommended every 10 years if you don't find any polyps. And one of the things that has happened with colon cancer screening is, the age-adjusted colon cancer mortality rates have fallen. And we don't know always. That's, again, these are associations. It's not necessarily just because of screening, but, this is a good test. Again, colon cancers grow fairly slowly. Remember, screening works well in cancers where the growth rates are relatively slow, because you can find it early and at a time where your interventions are better. So if you don't find a polyp, it's every 10 years. And most people are not begging to come in and get an extra colonoscopy. I don't ever hear that. It might be 3 to 5 years if polyps are found, and if you happen to have familial polyposis or one of the mutations, that would be when you would screen every year. So and then we've got other tests like Cologuard where you can, get your blood tested. It's a much simpler test and you don't have to get a colonoscopy as long as that's negative. So there's lots of ways in which we've tried to, again, reduce the burden of screening. Okay, next slide. So now I'll show you the cervical cancer example. And I think this is actually a very important illustration, because this is one of the things that got me thinking that we needed to change the way we screened. So there are two things about cervical cancer screening. So remember, cervical cancer screening really started with the Papa-Nicolau test, and this is one of the first cancers that we started screening with. And this was really started in the late 60s, early 70s. And what's been interesting about this is the colon cancer rates, the cervical cancer rates, the invasive cancer rates have continued to decline. But one of the things that came up was that, again, and this is actually something, believe it or not, I worked on in 1978, 1979, where we predicted, based on the growth rates of cervical cancer, that the screening rate should be every 3 years, and that it actually would work out better for people. There would be fewer false positives and people coming in and getting scared. And there are two things that were very important about cervical cancer screening. And we used to call it, stage 0 cancer. And, now the name for the abnormal Pap tests have turned to cervical neoplasia. No word cancer is in there. That's different from ductal carcinoma in situ. And that is actually one of the things that a number of us are trying to push for. And it didn't frighten people about screening. People aren't coming in and having their cervixes removed and hysterectomies for cervical neoplasia. There are simpler things that can be done. So this is like your perfect screening test in many ways, right? And there's now different things where we can look at risk based on HPV positivity, et cetera. Okay, so, and what's important is, as you start finding or treating some of those early lesions, your invasive cancer rates go down. So next slide. So one of the things here take a minute to understand this. So on the left, we have, screening started around 1980, right? 1985-ish. And you start to see on the top line, the very top line, you see the overall invasive cancer rates kind of going up. This is the Women's Health Initiative data where the cancer rates went down. But what you see here is this big increase in this blue line, which was the early cancers, and some decrease in the node positive ones, and that's this line, exactly, Allison, but nowhere near as much as what was going on here, and no change in the patients presenting with metastatic disease. Now, all the way over on the right, when you start to say, well, what fraction of localized cancer is a percentage of total cancer incidence? That went up. And we thought, wow, what a success. This is great. But the problem here is we're also finding more of these low-risk cancers. So it's not just that we're finding that we're substituting it for the high-risk cancers. So it's a little bit like the prostate cancer story, where you're doing more biopsies and finding more Gleason 3+3s. So we're finding some of these very low risk and we've started to learn that, again, if you're 70 and you have a 4 millimeter cancer, you can have a lumpectomy, you don't need radiation, you can have 2 years of hormone therapy, you don't have to be treated in the same way. So we're starting to learn to treat people really a lot differently. So these are the kinds of things that made me think, well, we need to be thinking about how to tailor our screening better based on who's at risk for what. So next slide, we're going to go back to that whole slide about, are people every year versus every other year has really gotten politicized. And people, it's like religion. People are, very strong on one side or the other. But let's go back to this idea, if you find a cancer under 2 centimeters, it's actually equally treatable with identical outcomes. If you have a stage 1 hormone receptor positive, kind of slow growing cancer, you're going to get endocrine therapy and your outcomes are going to be good. There is a small risk that a cancer could recur up to 15 years later. We haven't quite figured out exactly for whom that's true, but that's true really across the board. And for stage 1 cancers that are, even HER2 positive or triple negative, they get less aggressive therapy than if they have node positive disease. So part of the reason that mortality is not impacted up to 2 centimeters is because of improvements in treatments and outcomes, and because it's a lower stage. But it's not like it's different if it's, 9 millimeters versus 14 millimeters, and an extra year might be just that. So a lot of people say, well, oh my gosh, if I found a cancer at 2 years and I didn't screen at 1 year, isn't my life now under threat? Well, actually not. If it's node positive, that's a problem. That's much more of a problem. But we're finding that that's why that's a big mouthful. Do people understand that?
Just to reiterate what you said, I think, or just to recap what you said, is that there are some cancers that will arise that whether you catch them at 1 year or 2 years, your treatment options will not change. You'll have the same treatment options and your mortality won't be impacted. Is that correct?
That's right. So go to the next slide. That just we're going to go back to that, the graph. Actually, let's see, do we have the next slide? Let me just see. I'm looking for here, and then we'll go back to that other slide. So again, here we've got these really slow growing cancers. We want to make sure we don't overtreat the A's and maybe some of the B's. These vertical lines are the rates of screening, right? So you can imagine, you still have plenty of time to find this kind of localized cancer, even if you're screening every 2 years, and plenty of time to get the same good outcome. But that is not true for tumor D. There, we have to do a better job of understanding who's at risk for these kinds of cancers. That's really where screening is falling short. And I think tumor A, a lot of these are like DCIS and various things where we are for sure overtreating people. And active surveillance for DCIS, that we're going to do a big national study for that, because I think probably, the majority of people get overtreated for those kinds of cancers, and we should at least start generating options. So, so again, screening really does need to reflect our understanding of breast cancer biology. So let's go back to the slide before, Allison.
And just one clarification too, I know we hear often people just want, if they know that there's something there, or if there's even a possibility of there's something being there, they just want to take care of it. They want it out. They want to be done with it. And I think that the idea of over treatment is sometimes hard to understand. Just from your clinical experience, if you have any just information you can share about where there has been some harm in treating when something doesn't need to be treated.
Well, in our active surveillance study of DCIS, what we found is maybe 60-70% of people might not ever need surgery, and they certainly don't need radiation. I would say that, we've learned that for solitary lesions, radiation doesn't add as much benefit as we used to think it did. And certainly for women 65 and older, there is no mortality benefit to doing radiation. And so people who might live far from a radiation facility, for example, don't have to choose between lumpectomy and mastectomy anymore. And probably what's more important is using, at least a couple of years, if not 5 years, of endocrine therapy And because we can reduce the chance of that cancer coming back anywhere or any new cancer arising. So that's actually, very important. And, now there are options, especially in stage 0 for DCIS. There's baby TAM, which is 5 milligrams, as opposed to 20, much lower doses. There's lots, I think, and there's lots new types of endocrine treatments being developed, which is exciting.
Dr. Esterman, can you tell us a little bit more? So on this slide, tumor D, that, just so that everyone understands, that's the most aggressive cancer, and you're
That's
suggesting that cancer will not even be caught by annual mammograms. Is my understanding?
Right. That's correct. So I run another trial called the I-SPY 2 trial. This is for women with stage 2 and 3 breast cancer. So more advanced breast cancer. So even the most advanced you can be without being metastatic. And the vast majority of these patients show up with symptoms. They're not caught through screening, either because they're younger than 40, or these cancers grow fairly fast. So I can tell you from my own practice, we are not finding those early. And in fact, we are not operating on these people. We are trying to develop more targeted therapies so that we understand better how to treat them before they get to the operating room, so we know how to make the tumors go away, so that we have confidence that we've come up with the right treatment. So, and we're doing that with some of the endocrine treatments as well. And so the old traditional way of thinking surgery first is not necessarily the smartest thing to do, because you have a way to try and figure out, if you think about it, your treatments often last quite a long period of time. If you just take a short period of that time and try and kind of change the order of therapy, you can learn about whether you've gotten the right treatment and whether that's, you can do maybe a shorter course or a longer course, and what else you can tailor the therapy. And if you can make the tumor go away, the types of surgical treatments and radiation treatments you need can be quite a bit less. So that's kind of the new, more modern way of thinking about it. So again, we tailor our treatments based on biology and tumor type. It only stands to reason that we should be doing the same thing with screening. We have
Laura,
to connect the dots.
There's a question in the chat of what DCIS is, which I think got answered in the chat. But if you want to make any other comments about DCIS.
Yeah, so DCIS is when the cells build up within the milk duct, but they don't leave the milk duct. They're stuck there. And, the body often is containing them. DCIS by itself is not life-threatening. So there's no emergency. And I think a lot of times people are told they have to have this removed and they have to be in the operating room in 2 or 3 weeks. And, that is just simply not true. It's not an emergency. You have time to think about it, look for other trials. There's different ways of thinking about it. There's a big trial that's been ongoing that I think is almost finished, which is the COMET study, which was, randomizing or, with the flip of a coin, either having people just be given active surveillance with some kind of endocrine therapy treatment and versus going to the operating room and seeing if that's sufficient, that people don't need to go to the operating room at all. And, we actually have a big study that we're about to start very similar, where we're looking at, how people respond. And we're actually trying to develop better and more tolerable agents to see whether we can do a better job of preventing cancer from developing. I think DCIS, in my book, is a window to prevention. It tells you a little bit about the type of tumor you might develop, but it doesn't mean that you're necessarily going to develop it, but it gives us a chance to start thinking about how can we develop the right kinds of treatments, for prevention. So we've been operating on people and taking out 60 or 70,000 of these cases, 60,000 cases a year. And again, we're not really dropping the invasive cancer rates in the way that we were with cervical cancer screening. So certainly not all of these are destined to progress.
And another question in the chat, Laura, do women of color and younger women who have more aggressive types of breast cancer have time to wait for treatment?
It depends what you have. So you mean with DCIS, it depends on the type. If you have a hormone positive DCIS, that's not HER2 positive, you do have time. If you have there's about 20% of these that are more aggressive. We are working on a vaccine, and we have a study. We've been pretty lucky. About half of them have just disappeared with the new vaccine we have. Actually, believe it or not, one of the medications is made by Moderna. We were working on this before COVID came along. It's an mRNA. It's basically what we call cytokines. It's basically things to stimulate the immune system. So there's two types, one that have really a lot of immune cells and some that have, and the other kind that is much more common that doesn't have any. And so they should be treated really quite differently. Again, it's not an emergency, like you have to do it tomorrow. You have 3 to 6 months. I mean, again, the body's containing it, right? So it's not like you're on the precipice of having it explode into invasive cancer. So it's not like you have to do something about it tomorrow. Obviously, if it's more aggressive, you want to either get in a trial of doing something different or have surgery. If it's the less aggressive kind, you've definitely got time.
And just to note too, Laura, that when you are diagnosed with a cancer or an invasive cancer specifically, that you should make sure that they understand, or your practice team understands the type of cancer you have and tailors your treatment to that type of breast cancer.
100%.
Critical.
And that's what we say. It's not leukemia where, your treatment has to start within a week. In the I-SPY trial, we take 3 weeks. If someone wants to protect their option to have kids and harvest eggs, that can take 3 weeks sometimes. That doesn't affect your outcomes. Again, it doesn't matter where you start. If you've got that targeted therapy and it's effective, you're going to do fine. And if it doesn't work, then your treatment can be adjusted. So these are kind of the new ways in which we're trying to tailor treatment in that treatment phase. Again, we want to bring this back to screening. So these types of tumors need to be screened, more and more often. So that brings us to wisdom. Go back one slide. So again, we're not finding the fast-growing tumors at earlier stages, as I said. We treat stage 0 cancers like stage 1. Our callback rates are high, and we're not using the tools we have to prevent breast cancer when we identify. Most of our models, predict for the slower growing hormone-driven cancers. So we need better models that actually take into account, personal risk factors like race, density, genetics. And as I've said before, the burden of screening is high, right? And while screening mammograms are free, diagnostic tests are not always. They often have a copay and they can be a lot. So if you need it, we want to do it. But if it's overkill, we don't want to have that burden physically, emotionally, or financial on people. So keep going forward. I think I'm going to talk about, so again, the faster growing tumors are more common in younger women. So, likely the cancers that benefit most from screening progress at a pace where screening every 24 months is sufficient, just like it is for cervical cancer or colon cancer. So again, this is not a big surprise. Next slide. So what have we learned from Wisdom 1.0? We learned that family history isn't a good screen for the presence of the genes that predispose to very high risk for breast cancer. Turns out that 60% of women who have these, don't have a family history. So we actually have, as I said, a test where we can do that easily. Again, it's turning out that still these fast-growing tumors, people are still presenting first with symptoms. We need to find those people earlier and screen them more often. And we have to do a better job of getting the risk categories or the risk buckets right. And the way to do that is to think about risk for fast-growing tumors and risk for slow-growing tumors. Next slide. So Wisdom 2.0 is going to be an important step forward. And I think it comes at a good time because the guidelines are now completely up in flux. And we're not going to randomize people. We're going to allow people to choose. If you want to get screening every year, you can choose that. If you want to be personalized, you can. And that genetic testing is a key piece of information because we can look for those very uncommon but important gene mutations. But instead of looking at 40, we should find those people even earlier. There's no reason a genetic test, your genes don't change. So we can actually screen people in their 30s. And there are two things that we learn, not only about those mutations, but again, poly, many, genic genes can now be harnessed, those combinations, to predict whether you're at risk for a fast or a slow-growing tumor. And so, if you're at risk for a fast-growing tumor, you need to be screened every 6 months. So screening every 2 years isn't the answer from that. That's where we differ from the USPSTF. And if you find a woman who's at a risk for a slow-growing tumor, one example is someone who has a CHEK2 mutation, all those cancers that develop are hormone positive, we have ways to prevent that from ever happening. So it's a great opportunity to consider risk reduction. And this way, the average risk women can screen every 2 years, decreasing the burden and starting at 50. And that really decreases the burden of screening quite substantially. And so when someone gets to the average risk of a 50-year-old, whether that's at 40, 45, or 50, that's when you would start screening. So that's the idea behind Wisdom 2.0. And all of this that I'm trying to explain about, screening is complicated. We are used to early detection saves lives. It turns out to be more complicated than that. And most people don't have an hour to listen to me ramble on. It's my intention to talk a little less, but so I'm interested to hear from people whether that's helpful in trying to explain sort of why we're trying to do what we're doing and what people think about it.
So there is one question about to getting the insurance companies to pay for screening. So how do we get healthcare screening test standards changed so that healthcare insurance companies will pay for these and more often screenings? So for those that are at high risk for those aggressive tumors that we'd be recommending more frequent screening, how can we get insurance companies to cover them?
So that's an excellent question. So we are teaming up with a group of 70,000 primary care providers that are part of a network that Optum has started, and they're going to participate in Wisdom. We're starting to talk to, we have been talking with a number of insurers, Blue Cross Blue Shield, United Healthcare, all these, to talk about it. But perhaps more importantly, we're working with NCQA, the National Center for Quality Assurance. They're the ones that do the HEDIS guidelines. And we are going to work on trying to make sure that if you are participating, in a trial, so if the US Preventive Task Force says, we really want to encourage research, then it's really important for, you know, for the general, for the people who are insuring and the NCQA guidelines to give people a star for participating. And again, I will tell you the reason why they should do it. It actually turns out to be, I mean, if you stayed in your insurance plan for 10 years, it's, very cost effective. Part of the problem is that people move insurance plans every 2 years. So that's always our challenge. But if we can, working with, NCQA, we can work on trying to change the way people are rewarded for trying to generate the new kind of data. I mean, if we keep doing things the same old way, I don't think we can ever hope to have anything better. I have to tell you, when I first started working on this, I think there was the iPhone 3 or something, and I thought I was being way out there, and I said, demand the iPhone 8. That's when I first started working on this. I don't know what on iPhone 14. So I had to say, demand the iPhone 20 or 2030 maybe.
And just to note too, so for those women that we find genetic risk, whether it's the pathogenic variants, the genes, or the smaller changes in your DNA, the SNPs, what we're estimating is a lifetime risk as well, lifetime risk of developing cancer. And those lifetime risks are part of the National Committee on.
They're part of the national guidelines, exactly.
The national guidelines.
All of that is covered already. Yeah. And so we actually are working and have, been working with patients to justify to payers why they should get additional screening. But it does remind me, Allison, we have to sort of, get working again with NCQA but we do have partners to go now with to show how this can work. It's a lot to make all these changes, for sure.
And then a question just to clarify too, that it sounds like early genetic testing is one step missing to determine risk for slow, fast, or unlikely cancer development, which should guide screening frequency. And I would say yes, but you have to go beyond just the genes themselves. Right, Laura?
That's right. And I will tell you that I thought that everybody should pay for the genetic testing as well. But I've given up on that, and I'm just out there raising money to try and make that happen.
In the insurance company.
I recognize. So that's we'll have to raise about $10 million to add another 50,000 women to the trial, but we can do it. We'll do it, and so that we will pay for the genetic testing.
Yeah, and just to clarify too, that the what we're estimating and what we're justifying these high risk women at high risk for these aggressive cancers is that you have a high lifetime risk, which is according to the current guidelines. Nothing has to change. The current guidelines say if you have over a X% risk, 20 to 30% risk, you should be screened more frequently.
Right. In fact, the American Cancer Society says if you have more than a 20% lifetime risk, you should be approved for an MRI. We think that should be closer to like 25, somewhere in the 25 to 30% risk. But so that's sort of what we're targeting. So that's already in US national guidelines.
And then another question about screening guidelines for dense breasts.
Big can of worms. Okay. So it's very discomforting to be told you've got very dense breast tissue and that you should be screened more often. Then the question is, what should you be screened with? So very commonly people have been, screened with ultrasound. And especially in the states where there are laws in place to do that. And even though ultrasound does increase the absolute chance of finding a cancer, the percent of cancer you'd find, the absolute numbers are quite small, and it winds up that you have many more biopsies. So like 90% of what gets biopsied turns out to be benign. So it generates a lot of biopsies. So we don't think it's the best test. If you really are at high risk and you have dense breast tissue, you need a contrast study. And that contrast study should be either an MRI, or there is now something called contrast enhanced mammography, which increasingly more people are starting to use. So tomosynthesis does not look like it's going to be the answer in improving, the findings in dense breast tissue. Maybe a little bit, but not that much. But I think IV contrast mammography is going to be something that turns out to be very important. It's not as expensive, anywhere near as expensive as MRI. It's much faster. It's, does require iodine contrast, but it's something that, people, the facilities, it's not that much to change from what you're doing. So there's a big study going on sort of looking at this. And there was just recently a study out of Australia that showed that I think it works to reduce the chance that you would find these, what we call interval cancers. So I think for high-risk women, some kind of contrast enhanced study is probably better. So again, dense breast tissue is one of the things that contributes to risk. When you put it in the model, if you have high risk, then you should get a contrast imaging study like MRI. Or if they're doing a study on contrast enhanced mammography, or they have it in your area, I would say that that's something to inquire about.
And then there's one last question about the councils. I think the guideline bodies that we've mentioned and the councils, the NCCN and the HEDIS, and if there are diversity and inclusion requirements, so that there are medical practitioners of color who are part of those decision-making bodies.
Well, not as much as you would think. And I think that, one of the big issues for us in Wisdom is we have, really worked hard to make sure, we initially opened it up to everyone, but found that we had a very low inclusion rate of African-American women. And that was something that was completely unacceptable to us. And we've worked really hard to change that. And, because again, most of the risk models were done in women with, European background, which is not African-American women, and, didn't include African women. And, we just cannot leave this group of women behind. It's just completely unacceptable. So the best way I know to go about it is to make sure that the data we generate is highly inclusive of African-American women, Latino women, that we want to have an overrepresentation of Black and brown women, so that we don't, so that we don't fall short and we don't repeat the mistakes of the past. And some of my colleagues, Fumio Lapade, others who are on this group, have worked incredibly hard. We picked sites that have more diverse backgrounds, that have, investigators who themselves, are women of color, or, Latina, so that we can really make sure that our study will represent the population of the United States appropriately.
And just to show this, just the projection of where we are in the study currently, Laura mentioned Wisdom 2.0. We have launched our initial version of Wisdom 2.0 for women 40 to 49, 40 to 74, our regular criteria that we've had all along. And then in October, we're hoping to launch to do that initial risk assessment in women in their 30s. So eligibility will go down to 30. And again, we're trying to time it with October for Breast Cancer Awareness Month and get the word out about this. The importance of doing risk assessment and understanding your risk, and really having that drive how often and when you start screening, rather than just looking at age.
Does that make sense to people? We'd love for you to write in and tell us what resonates with you and what you think makes the most sense, and what's the easiest way to explain it. As I said, no one has time to listen to me take 45 minutes to explain it.
Can you share an email address?
But I thought it was important. Yeah, so actually, Allison, you want to put up an email address that they can send it to? Or where do you want them to send comments? Yeah, June, I'd love to hear what you think. And I wanted to introduce also, I think Sadie Leary is on the call. This is a high school student who's actually interested in maybe starting a club and trying to get a group of young people to understand the issues and explain it to their parents and their friends. And sometimes I think people who are younger and looking at it with fresh eyes might have an easier, might give us some good ideas for how to make the case a little bit more simply. Yeah. Sadie, are you on? I think she was.
Yeah, she was on earlier.
Yeah, great.
Yes, I'm sorry.
So again, some people are asking about how to join Wisdom. What's the criteria? So anyone who has never had breast cancer or DCIS who is between 40 and 74 right now can register and join the Wisdom study. You can do it online. You don't need to go into a certain facility or be seen by a particular doctor. Everything can be done online. And again, in October, when we are looking to launch, women between 30 and 39 can join at that time point. If you know people who are in their 30s who are interested and you don't want to lose their enthusiasm about this, you can go onto our website and register, and we'll keep your information and then reach back out to you when you're ready to register. So we just encourage people to help us spread the word about the study. Again, really hoping to make sure people are aware that this is available. It's an opportunity for people to learn their risk and get genetic testing at no cost, and to really understand your own risk as you're making decisions about your own screening.
Oh, okay, perfect. Yes, we do. Currently, we do like myriad genetic screening. Well, it's still new to us and everything as well, but it's always good to kind of hear from other individuals and, of course, get that wisdom in regards to those studies, and see how we can develop things better here within our practice at Oklahoma City Indian Clinic.
Wonderful. Well, thank you for joining, and thank you everyone for joining.
And put your name in the chat, and we'll keep the link open for a minute, and Steph Goodman can reach out to you. So June, if you have some ideas, we'd love to hear from you, or anybody else. Just put your name in the chat and how we can reach you, so we can call and talk to you and get your ideas.
And with the registration, we have your email addresses. So we have the chat that we'll keep, so we can contact you. And again, I think this is an opportunity for everyone to learn and hopefully be able to contribute, so that we have that new data that the guidelines can look at and see how can we change, how should we change based on new information, instead of relying on the old data that's out there. So we all have the opportunity to be part of that change and hopefully help to clarify not just the guidelines, but also trying to improve the outcomes for women at risk for those aggressive cancers, and make sure they can get in and get screened. So lots of opportunity, and we would love to connect outside of this with people. If you have groups that you think we should share this information with, or other channels or forums that you think this information should get out through, we're happy to help provide more information to other groups as well. Yeah. Wonderful. Well, thank you so much, everyone, for joining. So this happens once a month. There is a survey that just popped up, so please do fill that out if you can. But this happens every month, the last Monday of every month at 4 o'clock Pacific time. So the next one is August the 28th. We don't have a topic quite yet. We've got lots in the idea bank. And if you have suggestions, please do let us know. I know the next people are really interested in hearing more about environmental risk factors. We did a short session on that earlier. Also about data and privacy, about prevention options and things like that. So there's a lot of opportunity for us to add more topics in. So we'd love to hear from you.
And please give us feedback and let us know what was helpful or what wasn't about today's discussion. All right,
Wonderful.
Everyone, I have to sign off. I have to get on some international panel that's starting in a minute.
Wonderful. And I'm just going to end the poll and share the results so people can see. It looks like people are still very interested in toxic and chemical exposures. wisdom participant experiences, more information about polygenic risk scores, et cetera. So thank you for providing your feedback, and we will let you know the topic for the next couple of months. And please do continue to share your feedback. We're very appreciative for you being here and for your feedback as well. Thanks so much.
Thank you.